So I'm mindful of time, so I think we'll get going. Huge welcome, everyone. Thank you so much for joining us on today's webinar. I'm Emily Evans. I'm Everyturn's Deputy Chief Exec, and I'm your host for today. If you joined either of our webinars or both of our webinars last week, then welcome back. Thank you so much for joining us again. And if you didn't join last week and you'd like to see the recordings, then please get in touch. We can share those with you. We had one webinar last week on clinical case management and then one on our specialist accommodation services. Today, we are going to be showcasing our crisis accommodation services. And we're delighted that we'll be joined by some Everyturn colleagues who are going to be talking you through our crisis accommodation model, as well as being joined by our partner Home Group, who will be sharing some insight on their short stay accommodation model. For anyone who's just been joining, can see a few more people have just been joining in the last minute. Very welcome to all of you. Feel free to pop in to the chat where you've joined us from today. Events like today are really important for us as a charity and not-for-profit provider of mental health services, and we're really keen to share what we're learning in the development of our new models. So today you're going to hear all about the kind of challenges that we face and how we've overcome them, as well as some of the challenges that we're still experiencing, and that's all in the hope that hopefully there's learning there within what we're sharing today for all of you who have joined us. You'll also really importantly hear about the impact that these delivery models are making to people's lives. And again, as a not-for-profit provider and a charity, that's really important to us, that we can showcase and share the voices and the experiences of the people that we're supporting through all of our services. Just a little bit of housekeeping before I hand in to Rosie. Please, when the presenters are presenting, please can you keep your cameras off and your mics on mute. That just really helps in terms of the internet connection, making sure we can share everything. The session is being recorded, so we will share that afterwards. It won't be immediately afterwards because we just have to get the recording, but we will be sharing a recording afterwards, so please feel free to share that, or if you can't join the whole session, you'll get to see it afterwards. We are sharing a couple of case studies today, so we have got consent, just so you're aware, to share those case studies. And lastly, the chat function is open, as I've said. So thank you so much for those of you who have already shared where you've joined us from. As you're hearing from the presenters today, please feel free to pop your any questions or comments into the chat. We've got a Q&A section at the end, so we'll do our best to answer as many of those, and anything that we can't answer, we'll be answering and following up with you afterwards. So do pop your questions into there. That's the housekeeping out of the way, so I'm delighted to hand you over to Rosie, who's going to kick today's session off.
Hi everyone, I will just share my screen, so just let me know. Somebody give a thumbs up so I know you can all see it. Perfect. So, brilliant. So hi everyone, so my name's Rosie and I'm the Senior Partnerships Manager here at Everyturn. So as Emily said, thank you for registering for today's session. It is part 3 of the last in our Hospital to Home series, and this time we're focusing on crisis accommodation. So crisis accommodation plays a key role in helping people to remain safely in their own communities at times when they're in kind of real acute distress. It's also probably one of the services that we're asked about most frequently, but it can be quite a difficult model to get right. So I wanted to run today's session slightly different to the first two, just by opening some of the conversation around what some of the challenges that these services face are. And we've also, as Emily mentioned, brought in another provider to talk about their model as well. As we know, there's always multiple ways to do things. So with that being said, the plan for today's session is that I'm going to start by giving a bit of an introduction to Everyturn before handing over to Louise, who's going to, before giving a bit of an overview of our crisis accommodation offer, I'm then going to hand over to Louise, who'll provide a more detailed look at our call laying service, and then she's then going to hand over to James and Ellie from Home Group, who will share some details of their short stay bed offer in Whitehaven. I'll then finish just by talking through some of the wider potential system impacts and some of the things that you might wish to consider if you were hoping to set up a service in your area. So similar to the last two sessions, the plan is that it shouldn't take the whole hour. There should be time for question and answers at the end. But obviously there's a lot of people on the call, so just put any questions that you've got in the chat and Emily will bring them up at the end. If there's any we don't get through, we'll try and answer them in written form and I'll send it out with all of the other supported information after as well. So who are Everyturn, and apologies for everybody who's been on the last 2 sessions, because you could probably rehash this yourselves. So for anybody who doesn't know who we are, we're a mental health charity who have been delivering services for 40 years. We're founded in the North East, but we do deliver services nationally, primarily in partnership with the NHS, but also working with local authorities and other wider system partners. So our services are all structured around the 4 core themes that you can see on the screen. So we've got our specialist residential support services, our children and young person services, community and crisis services, and our NHS talk and therapy services. And they're all underpinned by the same core values. So everything we do is around improving individual quality of life and helping people to build their independence. We use lived experience to help shape and evolve our offer. And we're also really about working in partnership with health, social care and other community providers, including patients and carers, to try and create really integrated and holistic services. In terms of some of the specific services we offer, they all fall under those 4 key headings, but they can range from everything from 24-hour nursing-led specialist accommodation all the way through to our community outreach services, such as our Together in a Crisis and Safe Havens models. I've got loads of other information that I can share for anybody who wants it after the session, but that is us in a nutshell. So in terms of our crisis accommodation offer, so our core offer has been developed in partnership with the NHS, and that partnership has really been vital to the nature of the services mean that it can never be a standalone service. So from the offset, considerations need to be taken to establish how the service might fit in with existing pathways, particularly around acute services. So we know that anybody entering these services will likely need additional support from other teams. So we want to develop services collaboratively so we can really establish what that looks like and how that might work in practice. As you can imagine, one of the key partners that we work with in this model is the crisis teams, who in our offer act as a bit of a gatekeeper to the service. So they would potentially make any key decisions around admission and move on. And we know that part of their triage process anyway is that they would automatically be assessing people for any risk around self-harm or suicide or potential risk to others. They would be carrying out a mental state assessment, identifying any safeguarding concerns, as well as thinking about things like if there's any intoxication or substance misuse. And then they can use that information to decide, firstly, if that individual actually needs to come out of their current environment at all. And secondly, if they then need secure ward admission, or if they would be better suited to a community-based placement where they could receive the right care and support. Similar to our specialist accommodation offer, all of our crisis accommodation services are clinically led. They all have 24/7 care and support on site. And it's that clinical oversight that makes the model safe, responsive, and be able to work as a true alternative to admission. It also means that things like decisions can be made quite quickly, risks can be monitored effectively, and people can get the reassurance of knowing that help is right there when they need it, day or night. Having that round the clock presence also means that we're able to do things like take admissions as and when needed, which is a really important part of this offer. In terms of duration, so stays are usually short term, so they're normally just long enough to help somebody through the peak of their crisis, and that can range from anything from a few days up to a couple of weeks. Most services are intentionally small, so we're looking at kind of the number of beds. It's always shaped by local demand, but the typical service tends to be between 2 and 6 beds, and that scale isn't accidental. So it's that scale that helps to create a homely, settling environment rather than something that feels very clinical, noisy, or overwhelming. But it's all about striking the right balance. So it's about making sure that there's always a bed available when somebody needs it, but not holding so much unused capacity that the service is potentially carrying lots of voids. At the same time, experience has taught us that these services work better when they're smaller. So when too many people are in the service at once, it becomes quite difficult to maintain the calm, contained atmosphere that the people using the service need. So keeping the scale manageable helps to ensure that the environment stays safe, supportive, and properly staffed, so individuals can receive the focused attention and level of care that is essential during a crisis. Linked to that, our crisis bed services are often intentionally joined to one of our other specialist accommodation services, and there's a really practical reason for that. So as mentioned, the crisis bed services are usually quite small in number, yet we still feel you need a team who could operate 24/7. We want to try and avoid any lone working, and we want the right blend of clinical and non-clinical expertise. And to get that right in a small standalone crisis service could be quite costly. So by linking those crisis beds into a larger service, it means that we can share some of that staffing infrastructure in a way that helps to strengthen both safety and efficiency, That broader team also allows us to flex staffing levels in response to need, manage risk more effectively, and ensure that the right skills are available at the right time. It also helps to avoid any unnecessary duplication of roles and resources, so it helps create better value for commissioners and the wider system, but also by making sure that the services are safe and we're delivering that high quality care that people need. In terms of properties and estates, so our buildings play a really big part in how we support people. So we put a lot of thought in making sure that they do genuinely feel connected to the communities around them. So most of our services sit right within local neighbourhoods. They're close to shops, green spaces, transport links, and all of the everyday things that people need to help them stay grounded. Inside, the spaces are designed to be really welcoming and easy to navigate. And each service includes warm communal areas, so things like shared lounges, kitchens, gardens. So it gives people the space to chat, unwind, or potentially spend time outside if they want to. We make sure our staff also have dedicated areas as well, so any teams have what they need to work well and be present for the people that they're supporting. And just like our support offer, our estate is really adaptable and considered. So some services might sit within larger buildings with lots of bedrooms and shared spaces. Others might be delivered through clusters of smaller homes that help create more of a domestic feel. The setup can vary, but the intention's always the same. So it's always around creating that environment that genuinely fits the need of the people who are using it. So everything is designed to feel safe, homely, reassuring, and a place where people can settle to feel part of their community and just start to move forward. It's also worth mentioning that because our crisis accommodation is often linked to a bigger specialist accommodation service, we also then have to think carefully about where those crisis beds sit within the overall layout. So we know that people arriving in crisis can have very different needs. So some might need quick and easy access to staff support, others might need space away from busier communal areas, and some might require closer observation to help manage their risk safely. So the positioning of the beds really matters, and we plan this thoughtfully and work in partnership and have all of those conversations so that the environment supports people's safety as well as their dignity and comfort. We also take into account things like gender, levels of vulnerability, and also the need for privacy or quieter space. So in practice, that might mean locating crisis bedrooms closer to staff hubs, ensuring clear lines of sight, or placing them in areas that might reduce noise or overstimulation. But it's all about making sure people feel safe and supported, whilst also allowing the rest of the service to run as smoothly as possible. Next, I just want to talk a little bit about how we approach setting up and mobilising crisis services. So when we start shaping a new service, the first step is always about understanding exactly where it's going to fit within the wider acute mental health pathway. So crisis beds sit alongside everything from crisis teams, inpatient wards, emergency departments, as well as community services. So we look really closely at the local system and the pressures within it and how that crisis accommodation is going to be used to support flow and prevent escalation. We also know that crisis demand can be quite unpredictable. So there's going to be periods where it's a little bit more quiet and then other periods where it sees a sudden increase in referrals. So because of that, we try to build adaptability in the model right from the outset. So the service has to have or where possible, has to have the ability to flex. And one of the key enablers of that is when we do link it to another service. And that gives us that ability to increase or decrease the number of crisis beds that are available or change where in the building or estate those beds are located. In all of this design work, the voices of people with lived experience are really central. So we actively try to involve people who have used crisis services before, as well as their family and carers, just to help shape what that environment should feel like, what support is going to be available, and also how that support is delivered. Because their insight's obviously invaluable. It really grounds the model in real human experience rather than basing it all on our own assumptions. Another major part of the mobilisation is how we link in with crisis teams and other acute services. So we co-design joint processes for everything from referrals, admissions, and move on, just so people experience that smooth, coordinated journey without unnecessary delays. We also agree shared approaches to things like communication, risk management, and where possible, try to create space within the building for crisis team colleagues to work and hot desk, because we think that when we create that kind of proximity between the teams, it really helps to build relationships, which then leads on to things like improved decision making or speeds up decision making, as well as supporting safer and more responsive care. When it comes to funding, all of our crisis services operate on block funded contracts, and that's just because of the nature of crisis care. So obviously, by nature, it is quite short stays. And people need urgent access, so it makes spot purchasing quite challenging. So people just to put it bluntly, can't really wait for slow funding approval processes when they're in that acute distress. So block funding allows the service to run really safely, but it also means that individuals get access to the right staffing and availability whilst offering commissioners predictable and stable costs. But as an organisation, we're really transparent with our financial models. So we do share any assumptions, any cost drivers as openly as possible, so everybody really understands what's needed and what the service will be delivering. In terms of support, so at Everyturn, all of our crisis accommodation services are built around having a strong clinically informed team structure with a really solid governance sitting behind it to help keep people safe. And because we're supporting individuals at some of the most intense and vulnerable moments in their lives, we want to make sure that there's always that right mix of clinical expertise and therapeutic support on hand. So practically what that looks like is on each shift, there's always at least one clinically trained lead on duty, either a registered mental health nurse or a registered general nurse, because we feel that having that level of clinical oversight available 24/7 just means that we can then respond quickly to changes in somebody's presentation. It means the team can manage risk confidently and just make decisions that are rooted in that professional judgment. Working alongside the clinical leads are our nurse support practitioners, as well as a team of support workers, all of which are really experienced in delivering trauma-informed and person-centred support and care. And together, that layered team brings the balance of reassurance, relational support, and clinical skills that crisis accommodation really relies on. Each service also then has a dedicated service manager who holds operational responsibility, so they ensure that the service is performing as it should and that staff are well supported. They then work closely with the clinical lead, who focuses on treatment planning, pathways, evidence-based interventions, as well as staff development. And both of those roles are held by qualified nurses, so there's always multiple clinicians on duty at any one time. Behind the local teams, we also have strong central clinical governance infrastructure. So that includes our senior clinicians who provide everything from professional supervision. They oversee clinical quality and make sure that teams are continually learning and improving. They also carry out things like regular audits. They offer advice on complex situations, and they support team with escalation. So nobody in a team should ever feel like they're left on their own or they're working in isolation. We then also have clear policies, procedures, and escalation pathways that are developed and maintained centrally. So that means that all of our crisis accommodation services work in a consistent, safe, and evidence-based way while still being able to adapt to the needs of the local population. I'm now going to hand over to the lovely Louise, who's going to share some details of our Colway Lane service. Thank you very much. Oh, Louise, you're on mute.
That would be a good start, wouldn't it? Take myself off mute. So, hello everyone, my name is Louise and I am the service manager at Colway Lane within Everyturn. And I'm really pleased to be talking to you about our crisis services today and what we do, how we do it, and how we support people who are experiencing escalating mental health needs. So just to start by giving you a bit of a background as to why the service was developed. So there's currently no other crisis accommodation provision available within our region. And what we were seeing is a real need for an alternative to hospital for people whose mental health is deteriorating, and particularly for those who don't necessarily require hospital admission. So our service was developed to fill that gap. Our aim is to provide timely community-based support that prevents unnecessary inpatient stays while keeping people safe. And we're currently funded by the Newcastle and Gateshead ICB. Could I have the next slide, please? So looking at the key aims of our service, so our core aim is to offer a safe and secure supportive alternative to hospital for adults experiencing escalating mental health needs. So the service is quick access, so people can get support when they need it the most. It allows time and space for assessment, for symptoms to de-escalate, and for risks to be managed effectively. We've got close integration with crisis teams who continue to provide home-based treatment while service users are with us, and we're able to offer that accommodation and on-site support. So this partnership really helps us work towards the best outcomes for people. We offer a stable, calm and safe environment connected directly with our wider spread rehabilitation and recovery service. Everything we do is about giving people the chance to recover without the disruption and intensity of a hospital admission where this isn't clinically indicated. Have the next slide, please. So just to give you an overview of our service, so our crisis provision consists of 4 beds linked to a wider rehabilitation and recovery service. We can accommodate 2 males and 2 females at any given time. We support working age adults with escalating mental health needs that would all benefit from that alternative, a hospital, or simply a respite from their current living situation. To access the service users need to be a resident of the Newcastle and Gateshead area, and they must have capacity to consent to the admission. So we're not a locked unit, and people do and can come and go freely, and we do encourage that autonomy during their stay with ourselves. The crisis team act as gatekeepers for admission and discharge. So they choose who will come into service, who's able to access their service, and how long they stay. Throughout their period, we work closely with crisis services to plan for discharge, focusing on stabilisation, safety, and what support is needed once the immediate crisis period is passed. We do accept people into service 24/7. So crisis team would contact us by phone, make us aware of a potential admission, follow that up with a referral email, including biopsychosocial and a needs assessment, and then we respond and accept that referral within 1 hour. And service users stay with us up to 3 weeks. Could I get the next slide, please? So just want to talk you through our support model a little bit. So we are a service staffed 24/7, operating a nurse-led model. So this ensures that clinical oversight is available around the clock. One of our strengths is that we work flexibly across both of our crisis service and specialist mental health rehabilitation and recovery service. This not only creates cost efficiencies within the service, but it means we can maintain safe staffing levels wherever the demand might shift. So every person who stays with us receives a support plan, receives a needs support assessment, and from that we develop bespoke plans tailored to the individual needs. Throughout that stay, we carry out ongoing risk monitoring and able to provide that constant emotional and practical support. So that might include help with finances, daily living skills, or supporting someone to re-engage with community services. In addition, we also offer advocacy and advice services. We work closely with the individual, the clinicians, and the wider teams involved in someone's care. So our approach is needs focused, flexible, and grounded in collaboration, making sure that the support fits the person and not the other way around. Have the next slide, please. So our success, so we've seen a lot of positive outcomes since launching the service. A big part of that is our joint operating procedure with the crisis team. So we have regular communication, and the relationship between teams is strong and trusting, which makes a huge difference to how smoothly admissions and discharges run. For service users, we have seen some excellent outcomes, including overwhelmingly positive feedback and many successful discharges, and obviously avoidance of hospital admissions. Clinically, we've established strong infrastructure, robust risk management, and a culture of reflective practice, which helps us continually improve the service. And by Coelium being linked to a wider provision, we've also been able to achieve cost efficiencies alongside safer shared practices and improved risk management across the whole site within service. Could I get the next slide, please? So some of our challenges and learning. So like any service, we have faced challenges and learned things along the way. So one of the key challenges that we face is balancing the need of individuals staying with ourselves. Although we have a criteria for admission, we always have to consider the impact on other people currently in service, which means sometimes we can face tricky decisions around suitability and timing. One of our other challenges is ensuring maximum utilisation of the beds while still keeping ourselves responsive. And because referrals only come through crisis services, there may be opportunities to explore earlier intervention routes in the future, allowing people to access support before reaching full crisis point. These learning points are helping shape how we continue to refine and strengthen the model. Next slide, please. So I just want to now share with yourselves one of our service users' journeys. So I'm just want to read out his story for yourselves. So this is John's story, a story that reflects a difficult journey many people face when living with long-term mental health challenges, but also the powerful impact of timely and compassionate support provided by crisis services like Colway Lane. John is a middle-aged man who has been known as secondary mental health service for most of his adult life, experiencing ongoing anxiety and depression. For several years, John described feeling stable. He talked about living what he called a normal family life with his wife and children. This period of stability was extremely meaningful to him. Several years ago, prior to admission into Colway Lane, things started to change. His anxiety began to increase and episodes of low mood became more frequent. John took all the right steps. He sought help from his GP, made self-referrals for talk and therapies, and reached out to helplines such as the Samaritans. But despite trying multiple avenues, he struggled to find the support that truly met his needs. He eventually stopped taking his antidepressant medication, believing it was no longer working for him. Throughout his life and during difficult periods, John's family had always been a strong protective factor. But as his depression deepened, these relationships became strained. He began using alcohol and drugs as a way of coping, which added further pressure to an already fragile situation. John ultimately reached crisis point after being asked to leave the family home following an argument. Feeling overwhelmed, he went to a local bar with friends and used a combination of recreational drugs and alcohol. When he left, he made his way to a nearby wooded area and attempted to take his own life. Thankfully, John was found and taken to A&E. He was initially seen by PLT and referred to crisis team, who made a referral to Colway Lane. His social support network had broken down. He needed space to focus on recovery away from his children. He was experiencing ongoing suicidal thoughts and was identified as being a risk to himself. John stayed at Colway Lane for 3 weeks. During this time, several key aspects of support helped him stabilise and begin to rebuild. He was able to access constant emotional support from staff, something he hadn't experienced before due to changing clinicians and home-based treatment. This continuity allowed him to build trust. His risk was monitored closely with ongoing assessment and intervention. His antidepressant medication was restarted and given time for John to feel the benefits. He also learned coping strategies for moments of emotional overwhelm. This included guidance around PRN medication use and understanding when to use it, what alternatives to try first, and gain education around the risks of addiction. When John first arrived, he was withdrawn and expressed deep hopelessness. He spoke openly about feeling guilt for the relationship breakdown that mattered to him the most. He described himself as being at rock bottom. By the time John left Colway Lane, he was a different person. He felt motivated, engaged, and ready to continue his recovery journey. He began thinking about returning to work. The distance from home allowed emotions to settle and gave his relationship space to heal. John was able to return to the family home on discharge. Recently, John came back to Colway Lane, this time not for treatment, but to simply say thank you. He shared he'd continued to engage in support and had made a full recovery. He proudly told us he'd returned to work and had even received a promotion, which had brought him to the area. He expressed a deep gratitude, the kind that reminds us all why we do what we do. It was a really powerful moment and a reminder that even when someone is at their lowest point, the right support at the right time can completely change the direction of a life. Thank you for listening to John's story, and I would just like to go on to the next slide. So finally, I would like to leave you with some feedback we've received from people who've supported over the years. The quotes on the screen give a real insight into the positive impact Colway Lane's crisis provision has had on individuals during some of their most difficult times. And thank you for listening.
Thanks, Louise. Now I'd like to hand over to James Barra, who is the Senior Supported Operational Manager at Home Group. He's going to talk us through their crisis and short stay bed offer. Their service actually forms part of a wider offer in Copeland, part of Hope Haven model, which is one of the 24/7 neighbourhood mental health hub pilot schemes that both Home Group and Everyturn have been involved in. For anybody who is interested in hearing more about the full Hope Haven project, because it's a whole 2-3 hours on its own. It's a really big project that we will be dedicating a session in this series 2 of the webinars in May. And James and Ellie will be more than welcome to help join us in that. But for now, I'll hand over to James, and I've just seen Ellie pop up to share more about their short stay beds.
Thanks, Rosie. Yeah, and thanks to Everyturn for having us along. Unfortunately, James can't make it. He's lost his voice, so I've been drafted in at the last minute. So my name's Ellie O'Grady, and I'm the service manager for Hope Haven at Home Group. So we'll start with giving you a bit of an introduction to Home Group. So Home Group is a housing association, as many of you might recognise, but a housing association with a difference. So we're on a mission to build homes, independence and aspirations. We're one of the UK's largest housing healthcare providers. Home Group has been making a difference to people's lives since 1935. So we were created originally in the North East, but we now have a presence across large parts of England and Scotland. And Home Group currently support over 125,000 customers across more than 57,000 homes. So we work with NHS partners across the country to provide integrated health, housing and social care that really make a difference. Thanks, Rosie. So what is Hope Haven? So as Rosie's just said, Hope Haven is one of 6 national neighbourhood mental health pilot sites that's received funding from NHS England. So Hope Haven is a new model of delivering mental health support to people in Copeland. And so Copeland, for those of you that don't know, is part of North West Cumbria. Hope Haven brings together a wide range of partners to promote mental health wellbeing 24 hours a day, 365 days of the year. And Hope Haven is a partnership. So we have colleagues from Cumbria Health, Cumbria, Northumbrian, Tyne and Weir NHS Foundation Trust, so CNTW. We have colleagues in Everyturn Mental Health. Obviously, we're part of the partnership Home Group, but we're also joined by ICANN, Wellbeing Group, the Well Communities and Whitehaven Community Trust. So through those partners, we can provide a range of support. So anything from clinical mental health support from CNTW. We also have physical health support through our dedicated GP and healthcare assistants at Cumbria Health. Exercise and wellbeing activities are offered by our partners at ICANN. And Home Group and Everyturn offer health, housing, social support, access to the short stay beds, distress brief intervention, safe havens, together in a crisis model as well. The Well Communities, they offer drug, alcohol and peer support. And then our community asset base to run it all from is provided through the support of our partner, Whitehaven Community Trust. So Hope Haven aims to provide and promote mental health wellbeing through a range of interventions. It has a wide service offer. So we have a hub, which is opening this month. So really exciting time for Hope Haven. We're just about to move into our sort of forever home, as we call it. So that's opening this month, and that will be a walk-in facility where people can walk in without a referral to be seen and access our amazing support. We also offer drop-in community clinics across other parts of Copeland, so not just our Whitehaven Town Centre. We have something fantastic called the Wheels of Hope, which is a van that's branded with our Hope Haven branding, which brings Hope Haven to you. So to provide support to remote towns and localities across Copeland. Our partners Everyturn are delivering distress brief intervention, which is we know as DBI. They also deliver safe haven and together in the crisis support models. As part of Hope Haven, we can offer face-to-face support in the community and in people's homes. And to be a neighbourhood mental health site, one of the criteria was that we must deliver short stay accommodation beds. So that's what we'll focus on now. Thank you. So our short stay beds opened on the 18th of August in 2025, and they are managed by us at Home Group. So our beds are for people that do not require hospital admission, but for those people where there is sort of no other option, no other support currently available. We have 4 beds in our building, and the criteria to come into the beds is that you must be part of the population of Copeland or Allerdale, so our neighbouring area. We are a non-clinical support team, so we're made up of home group support workers, but we have wider support from the crisis team and those Hope Haven partners that I've just explained there. The rooms, very much the accommodation themselves are very much non-clinical, so we were going for a home from home type environment. We wanted people to feel as though they weren't in hospital. We used people from our wider partnerships, so we've got people with lived experience, and we use their input to help sort of design the rooms when we're in that development phase. Everybody coming into the building receives a welcome pack, which includes things like tea, coffee, milk, biscuits, sanitary products, toothbrush, deodorant, any essentials basically, because people can come in with varying needs and from sort of various scenarios. So we try and provide everything that people need. We have a focus on arts and crafts, and we've got various activities dotted around for people to engage in. And we have a focus on getting people into the community. So where possible, we take everybody to our drop-in hub so that they can get used to that environment. So when they do return home, they feel more comfortable accessing the ongoing support that's available. So the stay for our model is usually 3 days, so up to 72 hours. We do have an incredibly tight working relationship with Crisis. So similar to Louise was saying, Crisis keep our beds as well, and they have direct access. But it's very much sort of a partnership decision. It's a joint decision between Crisis and Home Group as to whether or not someone can come in to receive the support, and we sort of share that risk. The Crisis teams visit people at least once a day for those 3 days that they're with us to ensure those joint care plans are succeeding. And then from there, we work with the person to fully understand their needs using a tool called Dialogue Plus. So once the person has helped us to understand their needs, we then bring in the wider partners as Hope Haven, and we wrap around the people. So everybody, for example, who is in our beds receives a full health check from our GP at Cumbria Health. So to date, since opening, we've supported 18 people through our accommodation. And just to sort of put that into context as a direct comparison from this time last year, there was 12 people in an inpatient setting, and this time this year there's less than 5. So we hope that we're really sort of taking that and sort of preventing people from needing that hospital admission. Each person who accesses the beds receives one-on-one support from a peer supporter as well. So someone with lived experience who offers support going forward, as well as to gather independent feedback on their stay. So the feedback to date has been incredibly positive. We've had comments sort of saying, I've never felt as listened to. People report feeling safe and calm during the stay, and the rooms feel like a home from home with comparisons to sort of city Airbnbs and things. If we move on, thank you. So we'll have a look at the short stay flats in action. So we're going to use a case study of George, which isn't his real name, but George came to stay with us at Hope Haven last year. Little was known about George before he came. He was recently involved with adult social care. He had a home with a registered provider, but had been evicted due to antisocial behaviour at his property and property damage. From there, George secured a private let with the help of Housing Options, close to where his previous home was. But the behaviour continued and a window was smashed by people visiting George, and again he was evicted. He found himself being placed into a hotel. Adult social care became involved due to concerns about his behaviour. George's cleanliness and personal hygiene was a problem, and George was displaying some strange behaviours, such as laying out items outside of his door in the communal area. George wasn't eating well and was refusing to eat. He had no money, but when he did have it, he didn't manage it well. George wouldn't engage well with agencies or the hotel staff, and at times became irritable, and some may have labelled him aggressive. George was seen as a bit of a difficult character to engage with, and the hotel staff eventually asked George to leave due to his behaviours. and that's how he came to stop with us at the short stay beds. At first, George was a bit reserved, but after a couple of hours, he struck up a brilliant rapport with staff. George was happy and calm, but clearly needed support in some areas, which were likely to be previous areas of frustration for George. The staff became quickly aware that George was a bit forgetful, so we arranged a health visit from our Cumbria Health colleagues. A full health assessment was carried out, and it was queried as to whether or not George had a UTI. Staff were able to spend time with George to understand his behaviours and presentation, and to feed this, the partners help us build a better picture of George. George would say he wasn't hungry, but whenever he was offered food, he would eat it, and in particular, he would eat out of cold cans. George would often become anxious and frustrated when he had times and appointments, and staff noted he needed reminded every 5 or 10 minutes as to what time his appointment was, how long he needed to wait. This was previously seen as somewhat disruptive behaviour, but through the joint working of the teams, a concern was raised about his cognitive function. An assessment was arranged with the memory and later life team. George expressed how, where he lived previously, people took advantage of him and took over his flat, and that was the reason for his antisocial behaviour. George expressed how... Oh, sorry, my screen just went. I was concerned I was still connected. So George expressed how where he'd been living previously, people had taken advantage of him. There was little income, and so Home Group undertook a behaviour maximisation activity with George to understand and apply for other benefits that he was entitled to. It was clear that George wasn't in a position to return to the hotel, as the same cycle would continue, and it was also clear that George was unlikely to be able to manage a general needs tenancy due to his vulnerabilities and the risk of people taking advantage of him. So the Home Group team worked with adult social care colleagues to have an Emergency Care Act assessment undertaken. A place was secured for George in one of Home Group's alternative long-stay independent mental health services through the insight offered by the short stay beds team and wider partners. Adult social care colleagues were able to arrange emergency funding package, which enabled George to secure the placement. George stayed with the team in total for 5 days and then moved into his long-term home. He now has the right support in place through the support staff and adult social care, as well as clinical teams. And each team has a greater understanding of George, his needs, and how we can tailor support to ensure he maintains his well-being and his tenancy in future. And that's us. Thank you.
Thanks for that, Ellie. So just to finish, I'm going to talk a little bit about some of the wider system impacts. So we all know that crisis accommodation services play a really important role within the acute mental health pathway. So the idea is that they should be offering a genuine, safe alternative toward admission for people who don't require inpatient environment, but they do need that immediate round-the-clock support, and they do need kind of removing from their current environment. So a big part of what makes this model work is that close partnership with crisis teams. So these services give crisis practitioners a space where they can work with multiple individuals at once. They can provide in-reach support and continue home treatment plans, but from one central location. So that helps to create that smoother communication, enabling things like quicker decision making, but also much more joined up experience for anybody who's using the services. With regards to financial benefits, community crisis accommodation is on average, and we've looked at kind of a few different models, not just from Everyturn and Home Group, but kind of other ones, but it can be up to around half the cost of a ward stay if it's either a large service on its own or if it's built as part of a larger supported accommodation offer. So for example, Colway Lane and one of Home Group's other services as well is less than £200 per bed per night. But even as a standalone service, so even, you know, like Home Group's one that they've just talked about at Hope Haven, where it's 4 beds and it's standalone, and that staffing model kind of stands up on its own, it's still significantly cheaper than ward stay. So there's still cost efficiencies to be made. But that combination of that reduced inpatient admissions and more coordinated community support just means that commissioners can see a real meaningful return on investment alongside those better outcomes for the people who are using the service. But it all relies on the service being designed and used well. So that brings us on to the last slide. So what things might you need to consider to make sure that any crisis service you did set up gives the greatest value both for the system and for the individuals? So the starting point is always about really understanding the existing crisis and acute pathway and what's already in place. So thinking about how people currently move through services and where those crisis beds will sit within that pathway and that flow. Crisis accommodation needs to complement what's already working, whilst also filling that real specific gap around short stay intensive support for people who don't need a ward but shouldn't really remain at home. So it's important to think about how the service will integrate with other teams, especially, as we've mentioned, the crisis team. So they're usually the key partners. And in many areas, they do act as the gatekeeper for referrals. So teams need to work together to create a referral admission process that's really quick, consistent, and clinically safe. Demand is another big factor to consider. So crisis services tend to have smaller numbers of beds, but those beds need to turn over really quickly and they need to be available when people need them the most. So it's a real balancing act around keeping a bit of headroom for urgent admissions while still achieving good utilisation so that the services do remain viable. And that requires ongoing conversations with the crisis team and other parts of the system just to make sure that everybody has that shared understanding of thresholds, any expectations, how to refer in, and how quickly the service can respond and adapt. A key decision point is around clinical infrastructure. So you've heard about two different models today. Everyturn's model has clinical infrastructure within it and home groups doesn't. So some areas might want that clear clinical presence on site where there's nurses available to support the team and oversee risk and respond to changes in presentation, while other systems might prefer a non-clinical model where that day-to-day support is delivered by trained support staff, but the crisis team actually hold all of the clinical responsibility and risk oversight. And both models can work. It's the choice, I think, depends heavily on local need, understanding constraints around local workforce and where that clinical accountability is expected to sit. But whatever the setup, there's things that can really help. So things like shared access to clinical systems or agreed data sharing processes and stuff like that's really critical. So the crisis team and the accommodation staff can work really safely and cohesively together. And where you can model that in from the beginning, it's a real benefit. From a commissioning perspective, I don't think it works without it being block funded. And I mentioned it before, but people really do need rapid access. So we know that the stays are going to be short and the need for speed kind of makes spot purchasing just really challenging. And finally, a word on estates. So we spoke earlier about the challenges of balancing a safe standalone crisis service with the efficiencies of potentially linking crisis beds into a wider accommodation offer. So whilst being able to integrate those beds might be cost effective and it improves risk management through things like shared staffing teams, it also means that you need to think really carefully about how to manage that risk alongside the needs of others within the wider scheme. So that can make things like strict eligibility criteria quite hard to maintain. Good estate planning can really help to mitigate that. So it might, where it's possible, doing things like using separate buildings, self-contained units, or clearly zoned spaces to ensure that people who are in acute distress have the right environment while still benefiting from the shared infrastructure. The challenge with that is that it might take more time to set up because you might need to source different property options or invest capital in a bespoke solution, but getting that right really makes a huge difference both to safety and experience. Lastly, just to close, what I wanted to kind of say on this was there really is no one-size-fits-all model for crisis accommodation, and everything we've talked about today reflects why. So getting these services right takes real thoughtful planning, a clear understanding of local systems, and just honesty within the organisations to recognise when something isn't quite working and maybe needs to adapt or shift. So I think the most successful models are the ones that really do stay flexible or responsive or genuinely shaped by the needs of people they support. But as we've seen and heard from the case studies, that when those crisis accommodation services are designed and delivered well, the impact's huge. So they really do help people avoid the trauma of ward admission that they might not need and help to support them through what can be quite a frightening moment in a real safe and compassionate environment, which ultimately improves their long-term mental health and quality of life, and that in itself is invaluable. And on that note, I'll hand over to Emily, who's going to take us through any questions and answers.
Thanks so much, Rosie, and thank you to you, Louise and Ellie. I'm sure everyone will agree that's been a really insightful set of presentations and just fabulous to hear that holistic, really person-centred approach that is being taken through these services. We've got about 8 minutes left, so I'm going to try and go fairly quick fire through as many of these questions that we've got in the chat as possible. Thank you so much to those of you who've popped something in the chat. As I said at the beginning, if we run out of time, we will follow up and answer your questions offline. I'm going to put the first two questions together. So how do you manage people who require housing? And then how do you enable flow and step down for complex patients? Louise, if I can come briefly to you and then to Ellie to answer that question, that'd be lovely. Louise first.
Hi. So in terms of service users who come into crisis beds where accommodation has been an issue for them, where they may need to find an alternative provision on discharge, our team will work with social workers and housing and signpost service users to the appropriate people that need to access more suitable housing. And then in relation to step down service from hospital wards, so we really do have a focus on that within our rehabilitation and recovery beds. So supporting safe discharges from hospital into a nurse-led service, where risks can be monitored and service users can access that nursing intervention outside of that environment.
Brilliant. Thank you, Louise. And Kerry, who asked that question, Kerry, if you didn't watch or come along to our webinar last week on our specialist accommodation services, I really recommend checking out the recording of that, because that's a lot more focused on flow and step down for complex patients. Anything to add from your side in home group around managing people who require housing or step down for complex patients?
No, it's sort of very much echo in terms of the work that we would do while someone's with us. I think it's important to understand that we're not an emergency accommodation provision, and that sometimes can be a bit of a sort of pushback that we need to give. Sometimes we are there for people in mental health crisis. So that is something that we're all sort of learning in Copeland. Part of Hope Haven that's been developed is we have a twice daily MDT, which we call Team of the Day, and that brings together all the partners in Hope Haven as well as all the clinical teams within CNTW, and we would have an MDT twice a day. So that would very much help manage anybody sort of transitioning from an inpatient setting. We've got access to support from those clinical teams, which is invaluable for us.
Brilliant, thanks Ellie. And the next question is from Vanessa around our bed occupancy rate. I haven't got that to hand, and colleagues, please shout up if you have that. I don't think we've got that to hand today, Vanessa, but we can follow up with you. What I would say is, as Rosie said just at the end there, balancing that need to make sure we're getting really good utilisation alongside having availability for short notice and being able to turn around beds quickly is a real challenge for us. And I would say overall occupancy has been definitely a challenge in terms of these crisis beds, and has also been kind of mentioned. They're typically gatekept by the NHS Trust and the crisis team, but we are working really proactively with those teams to look at how we can make sure the flow and the utilisation of those beds is as strong as it can be. The next question was around CQC rating. So again, as we've mentioned, the crisis beds that we've highlighted today in Colway Lane are part of a rehabilitation unit that sits alongside it, and they are CQC registered, as all of our specialist nursing homes are. So yeah, we are CQC registered at Everyturn. We recently had a round of really positive inspections from the CQC. Ellie, I'm not sure in terms of home group whether your crisis bed model is CQC registered. If you wouldn't mind answering that.
Yeah, so we're not CQC registered, and we've sort of been in consultation, but we don't deliver any regulated activity. So we have got CQC services nationally, but Hope Haven isn't registered.
Thanks, Ellie. And another question for you, which was around any extensions. Are extensions offered for people who need to stay for longer than 3 days? For your model?
Yeah. So obviously we are a brand new service with sort of developing as we go. One of the key things we've learned in those early days is that it's tricky if someone comes in, especially over a weekend, because those are the sort of statutory services aren't operational over the weekend. So we can extend on a case-by-case basis. Again, we're very much a partnership, so we would share that decision making with the wider partners, but we have done it and we are able to do it where we can sort of justify the need.
Brilliant. thank you. And then Rosie, there is a question here around data demonstrating impact on acute mental health admissions and also acute ED admissions. I know you've done some work on this, and I know it's a challenging area to try and gather that data, but is there any kind of further insight to build on what you were talking about just at the end there in terms of impact?
Yes, it's a challenging one to get, to be honest. But I know, particularly with the home group one, with the Hope Haven stuff, because it's part of that wider Hope Haven pilot, they've been collecting that data quite acutely and quite recently. And as I think Ellie mentioned, their ward admissions went from 12 same period last year to 5 this year. And I think I'll have the data to send as well, but it was also a reduced impact on the crisis team caseload and things as well through some of the wider Hope Haven offer. But I'll be able to share all that over. I think it went down by 35% overall. Yeah. Brilliant.
Thanks, Rosie. And yeah, Philip, we can share that offline again if that would be helpful. I know the national evaluations for the 24/7 mental health hubs is due out over the summer as well, so I'm sure you get to have a look at that. I'm just going to have a look through and to see if we've had any more questions. We've got a couple of minutes left. Does this pathway include those with an LD diagnosis? Louise and Ellie, are you able to answer that?
Yeah. Our pathway absolutely does. As I mentioned, we have access to our colleagues at CNTW who are part of the LD team, and they've sort of done visits around the property and stuff and would be available on, to support if we did support somebody with learning disability.
Brilliant. And Louise?
Yes, our service is also accessible to people with learning disabilities. That our primary need is someone who's in mental health crisis, and all of the other things that someone might be experiencing or suffering with comes along with that person. So yeah.
Lovely. Thank you both. If there's any other questions that we've not managed to answer, apologies, we can follow up separately. There's contact details on the slides. Joe's just put in Rosie's details on there. So any kind of follow-up queries that you've got, if you want to arrange a follow-up conversation, we'd be really, really happy to do that. Thanks again to all of our presenters today. A huge thanks to so many of you for joining and engaging with the conversation today, and to those of you who have joined the other webinars, as I said last week. We will be running another series of webinars at the end of April. So this series is all about the shift of hospital to community. The next series is around illness to prevention. So a couple of dates for your diaries. On Tuesday, the 28th of April, we're going to be showcasing our crisis and community case management services. So this is a focus on assertive outreach and open access prevention services. On Tuesday, the 30th of April, we'll be showcasing our Safe Haven model. So this is our version of crisis cafes for open access mental health support, including out of hours. And then Wednesday, the 6th of May, we'll be showcasing more about the Hope Haven. So you've heard a bit about that today. That's the partnership approach to offering 24/7 neighbourhood mental health. So look out for more details on that. We will be in touch, but please pop those in your diary. And just again, a huge thank you to all of you who have joined us today. And please get in touch if you want to find out any more with any of us. Thanks so much.